Well, hello. Good morning, everyone. Here from the Alliance, my first day back at the Alliance office. Thank you for joining us for the first of a two-part webinar series on direct primary care by the Alliance. I am Melina Cambizzi, and I'm the Senior Vice President of Business Development and Strategic Marketing here at the Alliance. So before I introduce our presenters, I wanted to let you know that you're all in mute mode. And if you have questions during the webinar, please send them in the chat box. If you want to say something or respond to someone during the discussion, please raise your hand as it is shown here on the screen so that the green arrow is pointing up on the hand icon. So it is my pleasure to have here with us today Dr. Kayur Patel, Chief Medical Officer at Recraft MD, and Dr. David Usher, President and Founder of ReforMedicine. I will introduce each one of the speakers, and then we will start this presentation with a couple slides from the Alliance and then over to Dr. Patel. So Dr. Patel, I've known Dr. Patel for a couple years now, and he is known and he continues to disrupt the healthcare industry with his unique views on the right care. He currently serves, as I said, as the Chief Medical Officer for Recraft MD, a company laser-focused on providing the patients they serve that right care. And we'll talk more about that in this presentation. Recraft MD, a couple things about Recraft MD and its relationship with the Alliance. Recraft MD is the company that the Alliance, after a rigorous RFP, has chosen to help us bring high-value primary care to the markets and the employers we serve, in the form of community health centers that are shared by employers. We will talk a little more later about this, and also in more details in the next webinar and also following other presentations as well. Dr. Patel will discuss how and why traditional healthcare doesn't have the systems in place to deliver integrated health, and what we as employers can do to provide quality care to patients and incentivize providers appropriately. He will also provide an overview of direct primary care, what it is, and how it works. Then the second speaker for today is Dr. Usher. Dr. David Usher founded ReforMedicine, and as a matter of fact, we work closely with Dr. Usher because several of the Alliance member employers are utilizing his services. ReforMedicine is a low overhead family medical and medical weight loss practice that is affordable to employers and consumers alike. Working under a purely private medical model, Dr. Usher can innovate and offer to patients and employers creative, affordable solutions that large health systems are slower to adopt. In his former life, Dr. Usher was a family doctor at the Mayo Clinic in Eau Claire, and he served as the medical director of weight management services and chair of the Department of Family Practice at Mayo. Dr. Usher will discuss his background at Mayo and how this experience influenced him in 2011 to found a direct primary care practice that focuses on affordable high-value primary care. We work, as I said, very closely with Dr. Usher, and I would also like to note that there are several independent, fiercely independent, extraordinarily innovative services, solutions, providers in Wisconsin, and the Alliance is proud and happy and looks forward to closely working with all independent providers. So with that, let me talk a little bit about why direct primary care. I promise I will not speak a lot as we want to hear from our distinguished guests. So why direct primary care? As you know, the mission of the Alliance is to work on behalf of employers to negotiate better rates and higher quality with existing providers. But we're all beholden to primary care as is delivered by the existing healthcare system. And that means rigid appointments, limited options, and as we all have experienced, multiple tests and other treatments outside of the primary care setting. But direct primary care is different. It is different because DPC is delivered outside the traditional health systems, which means that providers have different incentives. Instead of aiming to generate more specialty care, more tests, more specialists, and more visits, DPC, and we also, by the way, often refer to DPC as advanced primary care or high-value primary care, exists to generate better health for employees and affordability for the employers who sponsor their health benefits. So for these reasons, and also for all the reasons we will discuss today, the Alliance has chosen direct-to-employers primary care as a strategic focus for 2020 and beyond. In collaboration with Proactive MD, we're opening a new community health center in Sun Prairie in the fall of 2020, either September or October of this year. We already have a number of interested employers, and we'll be using this as a shared site clinic, so no one employer has to go at it alone. We look forward to sharing more details with you in the future, but if you have interest in participating, please reach out to me. We hope that Dr. Patel and Dr. Usher can talk through why they decided to offer this service. And on June 25th, we will hear from a panel of our employers talking about how they're offering direct primary care and what it means to their business and their employees. So without further ado, Dr. Patel, I am going to turn this presentation over to you. And Paul, please turn it over to Dr. Patel's control. There we go. Fantastic.
First of all, Melina, I really appreciate the opportunity to speak to the group and deliver the message. What I wanted to share with you is this is a major automotive manufacturer that makes these cars, and the supply chain has been delayed by about 3 to 4 months because of the current events. Due to the delay in the supply event, they were not able to deliver this specific fiberglass that they use for the body of this vehicle. So they had to look at options of shutting down their entire plant. 3,000 employees will be laid off. These 3,000 men and women would line up for unemployment tomorrow morning and put a burden to the entire nation. These 3,000 men and women will have to think twice what they will put on the table for their kids tonight for dinner. And so it's all because of the supply chain. It's all because of the current events. Now, their rival competitor uses the same alloy material, the fiberglass, and they actually have 50,000 extra sheets that they can essentially lend out. And so you would think logically what would happen is these two CEOs would get together on a phone call and say, hey, we got to shut our plant down. You have material. Can we borrow that, sell it, maybe make a little profit off it? Whatever they do, you can actually sustain the other company. But that's not how it's going to work, right? This rival is going to figure out how to take a baseball bat and chop the other guy in the knees with both kneecaps at the same time. This is how the market is today for most of the manufacturing market space. Let's flip this around. I have a patient in the ICU at a hospital that has a very specific poisoning and needs this specific antidote, 2-PAM. And this hospital in the ICU doesn't have 2 vials. We actually need about 10. We're short at least 8 or 10 vials. So the next logical thing the pharmacist will do what? Call around and find out who has 2-PAM, the antidote. They've identified a hospital 30 minutes away on the south end of the town. So now you got 2 pharmacists. They've identified that they can deliver this medicine. Instead of the hospital A saying, hey, I'm going to send my security guy to pick it up, guess what the south end hospital is going to say? Stop, I'm going to send my guy to you because he'll save you 30-minute commute time. Now, these 2 pharmacists didn't have to call their CEOs, didn't have to call the directors. It was just the right thing to do. It truly delivers the right care. I mean, it's innate. It's the basic instinct. That's what you would do because you are dealing with another product here, I mean, healthcare. So overall, when you look at healthcare today, I know we have a lot of sort of things to fix and gaps in care, but overall, the heart is there. But It's the problem is how are we delivering it? It makes it so difficult to deliver certain things is why we delay in some of our care. So we have a good group, Melina, today in this audience. What if we took the entire audience and divided into 6 separate different areas or 7 different groups? And I said, I want to build this car. I want the fastest, the most efficient and safest vehicle on the planet. And we divide the room into 6, and we have unlimited money, unlimited budget. And I tell Group A, go find the best brakes money can buy. Group B, go find the best transmission money can buy. In Group C, et cetera, get the best of the best products that the industry has to offer so we get the best of everything. Then we bring it back into the central office and say, let's get the top-notch 100 best mechanics in the world. Again, money is not an option. It's unlimited money. So you would get the best mechanics money can buy. You got the best parts money can buy. Now I ask you, the group, you can even put it in the chat line, how long will it take to build this car? 6 months? 1 year? 2 years? 5 years? How long do you think it'll take? The best mechanics, the best products, all in one warehouse. You just got to put it together. And the answer to this is, we could be here another 10 years, my lifetime, and we will never have this car. Because no products talk to each other. Do you think the BMW is going to talk to the Porsche and the Porsche is going to talk to GM and GM is going to talk to Chrysler? It'll never happen. They are not going to talk. So it's not that we don't have the best ingredients. It's not that we don't have a recipe. It's just how to package it and deliver. We just can't do it because there's no communication. Nothing talks. Doesn't healthcare today feel like this? Healthcare today, think about it. We have the best surgeons, the best OR, best prosthesis, the best medications, antibiotics, cancer medicine, best of the best money can buy. We have the best surgeons, best internists, best family docs money can buy. Yet, we just can't deliver. And so when you start looking at this, you really realize that if we can make an impact in the delivery, we can maybe make a big dent. So our focus over the last 10 years has been, how do we change the delivery? I'm not here to invent the next drug. I don't want to invent the next CAT scan machine that does 300 bytes. I just want to recraft the delivery. If we can recraft the delivery, we can actually make an impact. So I want to spend a few minutes and just build and look and view what the healthcare system looks like today. So if we were to take all the services, right, the doctors, the nurses, and the healthcare system is delivering, and put it from left to right, and the left being the most minimal care, and the right being the most complex care. So you can go from wellness, urgent care, medications, imaging, specialty care, hard caths, and then going to surgeries, ICUs, and so forth. So you're going in a progression of complexity of care. So that's the floor. This is what healthcare is delivering. Then you have the consumers, the patients. Now, today's world, patients can access care at any point. They can go straight to ER. They can go straight to the primary care doc. They can even go straight to the cardiologist and get a cath tomorrow morning. So they can go anywhere in the spectrum. Then on top is the payers, right? The TPAs, the employers, the payer, and the consultants, and so forth. You got a stop loss on top. So if you look at this house, it's simple. 3 pieces: the provider of care, the patients, and the payers. Of these 3, who's the most incentivized to put value in healthcare or look at value every time something is being delivered? Out of this 3 pieces, the payers, the consumers, or the providers? It's the payers. The consumers don't really care. Some insurance is paying for it. They don't care. It's just a copay. And the providers have a system that doesn't incentivize them to make anyone healthy. So it's really the payers are the only ones today that are interested in fixing the health system. And that's why this conversation is to say, how can you, as the representation of the employers and the consultants of the employers, help cut cost and put value back into healthcare. But the problem with today is you have this sort of broken system. On top of that, on the bottom, we put a broken electronic medical system. So you put an electronic medical record system in there, and guess what? No one's talking. The CT guy doesn't talk to the lab guy doesn't talk to the cardiologist doesn't talk to the internist, nothing is talking. And in my lifetime, it will not talk. We've been talking about this for the last 10, 15 years, that there's going to be a uniform one electronic medical record. It is not happening. It will not happen. So you have this electronic medical record as a foundation in a semi-broken system. Now you made the entire system dysfunctional. And that's why our cost is high, because there's replication of data, replication of tests, replication of information, and we were just having an excessive cost. So as a solution, and everyone on this meeting is aware that we can reshuffle, unwind this model. If we can take the existing model and break it apart a little bit and re-glue it in the right place, we can create a version 1.0 direct primary care. And what I mean by that is we would take what's on the bottom, the basics, the wellness, the urgent care, the medication dispensing, take some of those basic principles or services and move it to the right side of the pillar. And by doing that, what we're doing, we're moving to the right side one block at a time and allowing that health center or the clinic, version 1.0, deliver that part of the care directly to the patients. And as an evolution, that's what we've seen. We've seen the first evolution of the health direct primary care, and now the second evolution is evolving. And by just doing this version 1.0, there's about a 7, 8, 10%, depends on what stats you have, a reduction in the overall healthcare spent by that particular employer. So let's say you go to the version 2.0. It's simple. All we are doing is taking what we can manage from the bottom, move those bricks to the right-hand side, one by one, whatever we can manage, whatever we can chew, whatever we can master. So what if we took now, made the primary care consistent, same primary care, not like an urgent care where you got a different doctor every day, but the same primary care. Then you have more involvement, you have more chronic disease management. So you're moving these bricks from the bottom to the right, and as you do, guess what happens to the savings? It goes up. So we're essentially, the goal is to say one by one, piece by piece, what can we move? And we can't move it all, but we can make a big impact. So if we were to just simply go to this version 2.0, you can easily save 15, 18% on the total healthcare spend. Let's look at version 3.0. So what do we mean by that? Again, take the blocks from the bottom and move them up. What if we were to take some of the consulting specialties? What if we were to negotiate imaging? Some of these other areas where we're not touching, if we can manage, that we can increase the savings and do the right thing and maintain the quality. So when we started looking at this and said, okay, who's doing this, right? I mean, so I Googled this about 8 years ago, and there were very few employers that were doing something creative, but this is a recent data that I was able to pull up last week, 2018. Top 10 employers in the country. Here they are, top 10. What do you think they have in common? What do you think these 10 guys have in common? This green illustrates that these folks, these companies who represent the top 10 employers in the country have a centers of excellence identified. That means they actually looked at and said, here's our surgery, here's our cost, how can we get value for our dollar and maintain quality? So they developed centers of excellence. And if you recall, Walmart was leading the pack. October 2012, they publicly announced to all of their employees that if you are going to have these 5 major surgeries, that you will get it done in our specialty areas by choice. And if you move the traffic there, that they'll eliminate the copay. So it was incentivizing the employees to shift to the centers of excellence. And soon later, next year, Lowe's and PepsiCo and Frito-Lay, they all followed suit. And Walmart pretty much led the pack in 2012. What did they do? What did Walmart say? They understand the entire complexity of healthcare. So what they said is that we have X number of, let's say, knee surgeries, 100 knee surgeries. So they said, how can I take my 100 knee surgeries and give that to the best highly qualified surgeon and get a price break, so I'm putting value and quality. And they were looking at surgeries, 5 major surgeries. What I suggest is they started there because they could. In a global, in a 50,000 view, when you sit with executives, they're looking and saying, what can we do at an executive level to make an impact on healthcare costs? That would be it. But we, as an employer group for smaller employers, need not look at that. We need to look at it and say, look, we need to make sure that the 100 knee surgeries that were supposed to be done, could it be only 80? If we delivered the right primary care, right specialty, right imaging, and directed them appropriately, maybe those 100 knee surgeries actually could have been just 80. And if that's the case, then we at least can say that we didn't even need to do 20 surgeries. It could have been managed conservatively. So we need to look at it and pin it from both ends. We need to be able to go from the lowest complexity and kind of meet somewhere in between. So when you go out into the the environment and are looking at options for your employers, what are you looking for? My suggestion, maybe these are the few things that you can keep on your checklist, or like shopping checklist, so to speak, when you're speaking to some of the folks that you want to partner with. First thing is, in my mind, you have to develop a quarterback for your system. So if I were to ask you, who's got the highest IQ in a football team, who would it be? The quarterback. Average IQ of a quarterback is about 145 IQ. This guy, the quarterback, knows where each one of the team players are, who's going to catch his ball, who's left-handed, who's right-handed, whose wrist is hurting, whose ankle is sore, who's not on A game today. He knows where to throw that ball. And this is the same analogy I'm using for our specialty care. The quarterback has to be the family doc who has the ability to navigate all the specialty care and know where the patient is going to be pinned. And as soon as the specialty care sees the patient, it needs to be pinned back to the primary care to reprocess what the next move is going to be. So unless you have the right clinician in the center, it's not going to work out. Because the key thing is not just to see a patient for flu and cold and cough and UTI, is to say, how can we manage the referral center? How can we manage the specialty center? How can we manage the data that comes back? Who do we send the patient to? That's the quarterback. Unless you identify that key person in the health center, it's not going to go anywhere. So the next thing is, whenever you set up the the workflow and see how many patients you have and the volume and what the model should look like, it becomes easy to get into this loop of saying, let's see 5 patients an hour, because it'll cut costs. But the key thing is, more time you spend with the patient. Take medicine 50 years back. More time you spend with the patient, more you're going to find issues that you can resolve. And the least expensive care is the primary care. So the more time you give to the primary care and the patient, the better off you are, because you're going to decrease some of the specialty referral patterns. And so think about it. Why is a quarterback the smartest guy on the team? Of course, his IQ is 145. That gives him an advantage. Why else? He's in the locker room spending time with the other team players. He knows everything about the team player who's not on their game. This is exactly what I'm driving at. If the physician and the patient spend more time, the better it'll be, because they'll understand what the next plan would be. So going back to saying, how do you put value into the health equation? And, in a simple CFO's mind is like, if I were to buy this suit and it's $50 and I got it from TJ Maxx, I'm going to say, wow, this is $50, good quality, cost is 50, value is there, buy the suit. What if this was a $2,000 suit, quality is great, feels good, but $2,000, you're not getting value out of that. So it's the formula is quality over cost, but in healthcare it's not. This is not the formula in healthcare. This is a CFO's formula in the normal marketplace. In healthcare, if your cardiologist is an amazing guy, good quality, normal cost, good value, but at 2 o'clock in the afternoon on Sunday, if that cardiologist is not going to take care of you, then what do you get? You get no access to a cardiologist at 2 in the afternoon on Sunday. You got zero value. So unless you have access to care, you will not get the value you need. Yet one more step forward we need to look at is who's offering you outcomes, who's measuring outcomes. That's going to add value. And this is what I'm driving at is the version, direct primary care version 1, version 2, version 3, whatever methodology you want to use, is that we're adding more parameters to measure, more parameters to be accountable for. So if you were getting outcomes measured and someone actually came to you and said, we will measure outcomes and you will pay on outcomes, then you have just increased the value. There's more skin in the game, the incentives are there, and it's very practical if you think about it. So I'm going to end with this. If I were to ask the group, what is the third leading cause of death in the United States? It's not cancer, it's not breast cancer, it's not cardiovascular disease, it's not COPD and smoking. It happens to be healthcare-related medical errors. It's 2.5 jumbo jet 747 fully loaded crashing into the Atlantic every night. That's the number of deaths are occurring directly related with medical errors. There's gaps in care, gaps in care. We have to have zero tolerance for errors. And it's unfortunate this is not news. This has been going on for 30 years. So it's no longer news. And it's unfortunate that our patients, our public, gets their news from CNN. Because it's not news, it doesn't hit CNN. It's 30 years old, data's the same, it hasn't changed a bit. So there's a lot of room for improvement in every facet. We can make an impact. This group can make an impact. You can make an impact in the employer market that you serve, in the way you can change the healthcare. Melina?
Thank you, Dr. Patel. Thank you very much. We already have several questions that have come in, but we will address them at the end. Dr. Usher, I would like to turn it over to you now, sir, and you have the next 20 minutes.
I had plenty of experience in kind of leadership and understanding some of the things that went into running a clinical practice. So in primary care, it's kind of a structural problem, and that is that it pays a family doctor or a primary care physician more to see 2 short appointments than it does to spend 1 long appointment. So we make more money if we see 2 15-minute appointments than if we see 1 30-minute appointment. And that's just going to incentivize people to work faster and see shorter appointments and so on. So I always wanted to take more time with my patients, so that was a bit of a problem for me. But what happened was when the Affordable Care Act came along, our patients already were complaining of not being able to pay their bills. Premiums were going to go up. Out-of-pocket costs were going to go up. And so we decided to step out of kind of standard primary care medicine and get into a direct pay model. When I say primary care providers are undervalued, Dr. Patel was mentioning that really primary care should be your quarterback. And I'll thank him for the really high IQ reference, although I don't know that that applies to me. But your quarterback should really be the one who knows where the ball is at all times and knows what's coming up in the game and so forth. But primary care, again, because they're of the reimbursement structure, it's really hard for us to do that in the existing kind of fee-for-service model. So primary care has kind of been bought up by the big clinics. Primary care is kind of used as a loss leader and a referral engine for referring people into bigger cost, higher cost procedures that this multi-specialty clinics and hospitals would make more money on. And then to the patient, even if they have good insurance, this year's charges becomes next year's premiums, as you all know. So over time, this just escalates the cost of things to the patient and basically everybody involved. This slide, maybe you've seen something like this. These are from the Kaiser Family Foundation. But basically, you can kind of see the graph on the left over 20 years. Overall premium costs have risen 340% or 17% a year in this survey. And if you look at the employee contribution, that's gone from 27% to 28%. So the employee has seen basically a 360% rise over that same 20 years. So employees are paying more and more and more. Now, if you look at the graph on the right, basically you can see how much the deductibles or the amount of money that the individuals on the hook for, even though they have insurance, has gone up over 8 times what their wages or earnings have gone up. So effectively what you're seeing is individuals knowing that cost of everything's going up and that they are on the hook for more, people just sit at home and delay care or avoid chronic disease care because they know the cost is so terrible. And I was seeing this a lot in the big system. What you have is somebody who has insurance, but effectively they're medically homeless because they won't come home and see their primary care doctor. They'll just sit and wait until things become really bad, and then they'll go to urgent care or emergency room. So we decided why do we want to do what we're doing? We think that better healthcare really starts with better primary care. And as Dr. Patel mentioned, we like to think of it as high-value primary care. High-value primary care starts with more time with patients, better access for patients to get to their providers. This leads to a deeper, kind of more trusting relationship with providers, and that trust really is a huge key when we're recommending certain things and so on. Patients want to go with somebody they trust. One of the other things is that we get to spend more time addressing root causes of a lot of problems. In our case, we do a lot of medical weight loss. So we have kind of a treat weight first strategy rather than kind of thinking overweight as a cosmetic problem. We see it as a root cause to literally a couple hundred different medical problems. So we treat that aggressively, just like we would high blood pressure or diabetes. Overall, you see we refer much less because we have more time with our patients. As Dr. Patel mentioned, if you have more time, you can get to the root cause and address that more readily in primary care. It's more affordable to patients, and it yields a better work style and a better lifestyle for providers, certainly. And direct primary care, a direct pay model allows for all of that. One of the things that a direct pay model, though, you can see, whether you're a benefits broker, a consultant, or advisor, or an employer, is the direct pay model is going to be a little disruptive, to be sure. So what we created back in 2011 started with a combination of primary care, obesity care, more time, more access, more affordability. And it was better. Our patients loved it. One of the things, just a side note, obesity is right up there among the top killers. About 300,000 deaths can be attributed to obesity every year. 42% of the population has obesity, and another 30% are overweight or pre-obese. So you really have to have an aggressive, effective strategy for obesity, in my humble opinion, to be doing real good primary care. In any case, at around 2013, a couple of years in, our first employer came to us, and we had some conversations about working with the membership model to do some near-site and on-site clinic work for them. And thus we kind of started down that road as well. Basically, this whole foundation was built on the idea that we did not want to get into the tail-chasing problem of billing third-party payers for on a fee-for-service basis. So we've avoided that for all 9 years of our existence. Just to give you a sense of the cost difference, this is our fee-for-service side, as you can see down the right, the far right side. These are most of these are pretty one-to-one kind of comparisons, but I just want to give you a sense of the differential in cost compared to one of the big clinics here in town. So what we've started doing is working with employers, and what we've learned over the years is basically we want to create a partnership. We think of the patient's financial health as being as important to their overall health as their physical well-being and their psychological well-being. If they're not doing well financially, if they're struggling, that's going to lead to all kinds of potential health problems, stress and alcohol and relationship issues and so forth. And likewise, employers have the same in an analogous sense. If the employer is not doing well financially, they're not going to be able to grow. They're going to have to lay people off. There are benefits they might not be able to offer. And so we see the employer in this case kind of like we see our patients, just like this financial health thing is very important. So we partner with the patient and the employer to try to be rowing, get us all rowing in the same direction, so that we wind up with healthier employers and a better financial situation, also healthier workforce for the employers. So some of the things we do with our employers is initially is just get in there with them and roll up our sleeves and try to understand their health plan goals and strategy. We use high-value primary care as a base. We do it either in a near-site model with our own clinics, or if the employer wants to do an on-site clinic, we can set one of those up as well, and just work right out of their space. Again, this is all based on trusting relationships with patients. Anything that the employer wants to do, if it doesn't come through a trusted primary care doctor, that may be perceived as just trying to cut costs. If it makes really good sense and it's really great care, and your quarterback is out there cheerleading for those things, then the patients will be more likely to understand that. We refer only to the providers network. I don't have all of our providers are trained to work very specifically with each employer's plan, so that we're sending them to places that are going to be the best value for the patient and the employer. And then, as Dr. Patel mentioned, there's at the end of the day, you want to be able to talk about what you're doing well, and so we report data back to the employers, sometimes through their TPAs for return on investment and value of investment kind of determinations. So this is kind of where we've gone. We started in 2011 with just me and my medical assistant over there on the left. Over 9 years, we've become 2 people to 22 people, and we have went from 0 employer clients to 11, and we're in 4 locations now, including 1 on-site clinic. This is from our on-site clinic. They kind of published this data where it says part of our overall strategy. They started changing their strategy before they brought us on. And you can say they already kind of bent their cost curve significantly. Even after adding us in that first year, their costs went down. So they're sitting on a whole different trajectory now, and there's a $7 million differential between what they might have been paying if they'd have stayed on the same trajectory versus what they're doing now with our on-site clinic as part of their strategy. So how do patients like this? Well, as Dr. Patel mentioned, this is a pretty popular way to go. And you have more time with your patients and can really not only see patients but actually hear them. That will get you a pretty high, what we call net promoter score. These are true things from people have said about us, but we survey our patients, and 99% of them would recommend what we do to others. So it's a very great way for patients to be seen. The COVID-19 response, everybody's got one. We have done the spacing and done a lot of e-visits. I don't want to read this whole list to you, but bottom line is we've checked in with employers frequently, talked to them about testing, antibody testing and virus testing and so on. Some unexpected outgrowth of this, something we weren't thinking about top of mind, is to be able to do more telemedicine, including with our medical weight loss program. So it hasn't been all bad on the COVID-19 side of things, but we've learned to adjust, as so many have. In summary, basically, primary care should be viewed differently from the rest of the more expensive health care in that it's something you want your patients to use. You want your people to be well, just like you want to change your oil and have a good set of tires on your car. You expect to spend that money and you budget for it. Primary care is something you want to be utilized. You want to do preventive care. If you have chronic illness, you want that well controlled. And then the insurance is for that other high cost stuff that comes along. And so to get different outcomes from primary care, you kind of have to pay for it differently. So direct primary care is perfectly situated to be that new model, because there really is no substitute for time. Building trust takes time. I would make my own little plug for making sure that people are thinking about the obesity pandemic. It truly is a disaster in this country. So whoever you're talking with, make sure they've got a good, effective approach for managing obesity. And then I just pitched in here that Dr. Patel mentioned this, the incentivizing the use of your direct primary care program is really important. Okay, Melina, that's all I got.
Yes, and so thank you, doctors, very much. We do have several questions and about 10 minutes to answer some of those. So let me start with Dr. Patel, either of you actually, either Dr. Patel or Dr. Usher. Mark is asking, we're building a clinic in conjunction with a few other area employers, and we're in a rural area. Can a DPC staffing work with a nurse practitioner or a physician assistant as lead at the clinic? Dr. Patel?
Yes, nurse practitioners and PAs, again, I think the key thing is what level of services are we trying to provide. For most part, nurse practitioners and PAs do a phenomenal job. It's really navigating the care for the community, for the specialty in your town. And of course, the resources, sometimes it's hard to recruit. Our number one problem right now is just getting the recruit in and moving into an area where you need help. So we have many practices that do run on nurse practitioners and PAs today.
Yes, thank you. Dr. Usher?
Same question?
Same question for now,
Yeah,
yes.
no, I would agree. We have, among our providers, I just have fantastic nurse practitioners and PA staff who I really trust implicitly. I agree with Dr. Patel. It's really a strategy issue from the standpoint of the employer and what it is they're trying to achieve as to how much they want to put into physician versus NP versus PA. There's just some cost differential there, and recruiting is tough. Recruiting is tough. Not everybody sees us as the quarterbacks.
Thank you. A question that I actually have, there's several more questions, but I have a question because we talked about both models, both the Proactive MD model and Dr. Usher ReforMedicine handling more than primary care. And I know we talked a bit about obesity, but I analyze, I'm one of the people that look at employers' data, and we know that behavioral health and musculoskeletal issues are a very big ticket item and often not only expensive for our employers, but often difficult to receive care, such as behavioral health. Could you talk a little bit about that, about other services that your clinic offers? Dr. Usher, I'll start with you and then move on to Dr. Patel.
Sure. We have contracted with licensed professional counselors to see patients within our office space on this is pre-COVID, of course. Since then, we've learned that, gosh, patients really kind of like that via telehealth. So that same counseling group has been providing telehealth services for our folks in the counseling realm so the patient doesn't even need to come into our office. So that has gone pretty well. We have not ourselves contracted directly with any kind of physical therapy or chiropractic, those kinds of things. Some of our employers have contracted directly with them and have PT on site, for example, and I do think that's a really valuable service. So that's what I would say about that.
Thank you. Dr. Patel?
Yes, the musculoskeletal and the physical therapy, all of our clinicians are trained in that direction, number one. Number two, we have one of our health centers right now that is having a full-time 40-hour physical therapist on site in conjunction with the clinician. So essentially that population of employees have access to a clinician and a physical therapist anytime. And we've deployed that about now 8-9 months, and we're looking at replicating this similar model in other areas, other health centers, based on size, volume, and the need. And looking at even options of doing in the smaller population, telehealth would be another option of getting, even those physical therapy, we can still do a lot of maneuvers through telehealth. And as far as behavioral health, and like David said, it's very telemedicine driven, especially behavioral health, and we're actually looking to recruit a full-time MD to help navigate the original first site and then multiply it across our centers.
Thank you, doctors. Another question by Nicole, is your clinic staffed by physicians? Nicole, I will take part of that question. I assume you're asking the Alliance, if the Alliance clinic is staffed by physicians, because clearly ReforMedicine, Dr. Usher is a family practice physician, still is, and will be, of course. So the answer is yes, Proactive MD has, and the Alliance have made the commitment to bring in a physician to staff the first clinic that we're going to be offering. But going back to what Dr. Patel and Dr. Usher said, it's a strategic decision, and we absolutely believe in the middle level provider offering services, the nurse practitioner and the physician assistant as leads at clinics, because this is first for the Alliance. We will have staffing by a physician. Kayur, do you have something to add to that, since ReforMedicine is making that commitment?
No, I agree. I think that's kind of in line with what we're saying.
Thank you. And Nicole, if I didn't answer your question appropriately, please write us and let us know. Another question by Mark. Do most of your employers in DPC models cover only those in their plan, or do they cover their entire employee population? And is it making it free critical for maximizing utilization? That's a great question, Mark. Dr. Patel, because again, it's ReforMedicine and Proactive MD have a unique model here. So Dr. Patel?
Yeah, so it depends on the employer. So most of our employers allow their employees that are on the health plan and their dependents all to join the DPC model. But there are very few employers that'll say only the employees and not the dependents. So again, just based on what the employer's needs are.
Thank you. And another question is, and I know, Tanya, I know you're directing it to ReforMedicine. I think it is appropriate for both the doctors. How do we offer MRIs, and how do we recommend where patients go to receive MRIs? David, would you mind telling us some of the strategies employers are using for that?
Right. If I can piggyback on that last question, one thing I would say is, because direct primary care is not insurance, employers can put anybody on the plan or allow anybody on the plan they want to involve. That, again, as Dr. Patel mentioned, that's just kind of employer dependent. So you can have part-time employees and so forth on your plan if you wish. What we do is, again, we look at what the employer's network is, and usually they'll have a high value set of centers that they've designated as the lowest price, the best deal for getting things like MRIs, CAT scans, specialty care, and so forth. So we always direct our patients to that resource person for their plan, and they then can inquire of them what their options are, and then the patient lets us know. Last thing we want to do is send the patient somewhere out of network and wind them up in medical bankruptcy. That's just not a very good wellness strategy for our patients. So that's how we do it basically, is make sure that the patient is interacting with their health plan.
And Dr. Patel, the same question for you. I know the Alliance and Proactive MD were working to exchange data so that as the Alliance controls cost data, because we control the contracts, you can have information of the most, and of course integrating with your quality metrics, the high value, how to send and where to send to high value specialists. But same question to you.
So specifically, you mentioned about the MRI or imaging, and it also goes to the specialty services too. So we have 44 clinics total right now, and each community is different. So each community we need to kind of customize in that area to say what are the resources, how far do they have to travel to get the MRI and or the specialty services, and each community we will actually maintain a database that says, okay, if you get an MRI here, here, or there, how quickly can you get in, who's reading it, and what the cost is. So essentially, we have a care navigator, a patient advocate that actually referees some of this for the patient so they're not lost in the system.
That's right. Yes, and we didn't talk about the patient advocates, but we will get an opportunity at a future webinar to talk about the patient advocates that come with the ReforMedicine, with the proactive, confusing the names, with the Proactive MD model. I have two questions here, both regarding RX. And so how do you approach to handling RX, both potentially pre-packaged medications, but also specialty drugs? Dr. Usher?
With regard to prescriptions, we are just inherently, it's our nature to use generics first, of course. We do dispense some prescriptions out of the office. We're actually looking at expanding that in the near future. But and often that just dispensing them out of the office can even save more money than what occurs under the PBM, for example, pharmacy benefits manager. And that's really convenient for the patient, particularly if they're not feeling well and you can get them their antibiotics and so forth. They don't have to go stand in line at the pharmacy, or high blood pressure drugs or diabetes drugs. People, if they can just send them with people, it's a very nice option. As far as specialty care drugs, we are working, the same thing occurs with basically the approach to how you get the MRI done. We kind of put people back in touch with their health plan, work with them as much as we can to understand whether or not they actually need the medication. That's one of the things that we don't really, we're not the specialists, but we do want to talk with the patient and see what the specialist is saying about their medication, just to make sure that this is really the best thing for them at the time. And so we'll kind of review that with them. But we will refer people to patient assistance programs sometimes, or a variety of things that maybe help take some of the cost out. But as far as specialty care drugs, we don't have a lot of direct control over that.
Right, absolutely. Dr. Patel, I see my clock. It tells me 12:01, and I have tons of questions. By the way, folks on the webinar, we completely understand if you need to drop off. We will answer these questions in collaboration with the two doctors and send to you. But Dr. Patel, I can't help myself. There is one more question that I'd like to address to you. And the question is, how do you capture avoidance of needing a surgery by improving primary care? And this comes to us from Dan, Dan is actually a client of Proactive MD currently.
So it's when we say surgery, let's take orthopedic surgery, musculoskeletal stent. If the patient comes to us, the primary care, and we navigate their care and we manage the imaging bring the imaging back to us and navigate it through the system. We're not saying that they don't need to go to orthopedic surgery. We're saying that could there be other options that are more viable, like physical therapy? And that's why we have a physical therapist on site. And the idea behind it is to say, if we can capture the patient early, keep them moving, keep the joint moving, and not actually put a needle in there yet. If it needs to, so be it. But we need to spend time gradually. And what usually a lot of times happens, patients will come in, I have knee pain, I want MRI, I want a needle, I want surgery. But there's this window of opportunity that we're missing. And if we can capture that, you'd be surprised how many surgeries we can avoid altogether. And statistics are very astonishing, especially for the musculoskeletal world, on how many surgeries can be avoided if we follow a pattern. And so what we're saying is we want to navigate their care in the community. Once they go down the path of getting a X-ray, MRI, and a needle, and the next thing is a scope, then they're just down that path.
Fantastic. And with that, we're 3 minutes over. Doctors, thank you so very much for your time. We hope to see everyone again June 23rd. For everyone on the webinar, all of those of you who have seen and I cannot see, thank you for the privilege of your time.
Hey, thank you.
Thanks, Melina. Bye-bye. Thanks, everyone.
Thank you.